Well, good afternoon. My name is Mariah Billups, and I'm pleased to welcome you to What's Up, Doc, a monthly lecture program brought to you by the Concord Hospital Trust. Concord Hospital Trust would like to recognize and thank the Walker Lecture Series for their generous sponsorship of What's Up, Doc. The Walker Lecture Series offered a wide variety of programs on history, literature, art, and science, as well as dramatic, musical, and literary performances. All events are free to the public and held at the Concord City Auditorium. We encourage you to check out their website to view the calendar of programs. What's Up, Doc is proud to welcome Dr. Alexandra Charos of Concord Dermatology as our guest physician today. Dr. Charos joined the healthcare system in 2021. She completed her dermatology residency at the University of Vermont, Burlington, serving as co-chief resident. She graduated cum laude with a bachelor's degree in biology from Harvard College prior to attending medical school at Temple University in Philadelphia, Pennsylvania. She completed an internship in pediatrics at Cohen Children's Medical Center at Northwell Health, the largest children's hospital in New York. In addition to her clinical training, she earned a PhD from Yale University in molecular, cellular, and developmental biology, and completed a postdoctoral research fellowship at the Yale School of Medicine in the field of melanoma research. Dr. Charos is a member of the American Academy of Dermatology and the American Society of Dermatologic Surgery, with special clinical interest in dermatologic surgery, general dermatology, and pediatric dermatology. So please welcome Dr. Charos.
Hi, thank you, Mariah, for that really kind introduction, and thank you to the organizers for setting this up so that we could talk with the public about dermatology. And I'd also like to thank everyone who came here today to attend. I hope you learned something. So my talk today is about skin health. I'm going to cover a few things. I'm going to cover normal skin, aging skin, and skin cancer. So skin is a very complex organ. It's the largest organ in your body. It weighs roughly 15% of your total body weight. And I wanted to start off with a background slide of a cross-section of skin. What you're looking at there is just a cartoon depicting skin. The top layer is the epidermis. And then the second layer of skin, the deeper layer, is the dermis. And it sits on top of a fat layer, which is the subcutaneous fat. The dermal layer contains a lot of different things. You have blood vessels, you have nerve fibers, you have specialized Merkel cells that detect touch. You have hair follicles. Your hair follicles are associated with sebaceous glands that produce oil and with apocrine glands that produce sweat. And you have separate eccrine sweat glands in the skin. The skin has many different functions that are important. It provides a protective barrier against injury. It also helps repair injury. It's an important component of the immune system. It helps prevent infections and autoimmunity. It prevents the loss of moisture from your body. It helps reduce the harmful effects of UV radiation. It acts as a sensory organ to touch and to temperature. It helps you regulate your temperature. And it's an important organ for vitamin D production. If the normal functions of the skin are disrupted, you can have problems. It can lead to dehydration. It can lead to infections with fungus, bacteria, or viruses. It can lead to problems with autoimmune diseases, cancer, vasculitis, which is inflammation of the blood vessels. You can have problems with your nerve and develop sensory neuropathies, itch, or pain. You can develop vitamin D deficiencies. It can lead to hypothermia or hyperthermia, photoaging, vitiligo, which is the loss of pigmentation in the skin, or hair loss. So unfortunately, the skin ages, as do our other organs like our eyes and our ears. Aging skin can be aged by UV radiation, and that's called photoaging. Which can result in brown spots on sun-exposed skin. It can also lead to thinning of the skin, especially on the forearms and the backs of the hands. And this is something that we call solar purpura, when you develop easy bruising on the backs of the hands or forearms. And this happens to over 50% of people over the age of 50. And unfortunately, if the sun thins out your skin, there's no way for us to thicken it back up. Aging skin can also be dry, and you can get benign skin growths with time. The most common ones being brown spots that are called seborrheic keratoses, or red spots that are benign collections of blood vessels that we call cherry angiomas. Your hair and nails can also age. So with time, you can get age-related hair loss, and your fingernails can become more brittle. Fortunately, there are some things that you can do to prevent loss of the normal function of the skin and to slow down this process of aging. One is avoiding sun exposure, so getting under an umbrella or seeking out the shade, avoiding tanning beds. Even a one-time use of a tanning bed can increase your risk of developing skin cancer. In the sunnier months, you can wear sun protective clothing, hats, long sleeves, and sunglasses, and you can also wear sunscreen. We recommend mineral sunscreens that contain zinc oxide and titanium dioxide. The higher the SPF, the more protection that you get, and we do recommend an SPF of at least 30. There are also lip balms that contain sunscreen, and you can wear these as well. Proper nutrition can also help with your skin health. So to maintain healthy skin, you need a wide variety of nutrients, vitamins, and minerals that come from a well-balanced diet. So some of these nutrients that are important for skin health are vitamin A, which you can get from fish, eggs, and dairy, vitamin C that you can get from citrus fruits, vitamin D that you can get from egg yolks, fortified yogurt, cereal, vitamin E, which you can find in nuts and seeds, zinc, which is an important mineral that you can find from beans, poultry, nuts, and whole grains, and finally, omega-3 fatty acids, which are rich in seafood, walnuts, chia seeds, and flax seeds. So in summary, I have some skincare tips for you. You can wear sunscreen daily, avoid tanning beds. You can simplify your skincare routine. There are a lot of products out there on the market, and most of them are not necessary for your skin health. So we recommend limiting washing your face to twice a day with a gentle, mild soap. And if your skin is dry or itchy, you can moisturize it. We recommend using fragrance-free products. Fragrance-free has a different definition from unscented legally. So fragrance-free products contain no fragrances. Products that are termed unscented can have masking fragrances in them, which can be irritating to the skin. We recommend that you choose skincare products formulated on your skin type. So you probably have a sense for whether your skin is sensitive or if you have normal skin or oily skin. Treat your lips and try to keep your hands off your face. So now I'm going to shift gears and talk about skin cancer, specifically in New Hampshire. This is a bar graph from the CDC website that talks about the top 10 cancer rates by new cases in the United States. Number 6 on the list is melanoma skin cancer. And unfortunately, in the state of New Hampshire, melanoma is 5th on the list of new cancer cases. Fortunately, melanoma is not in the top 10 list of most common cancer deaths, though. Doctors are diagnosing melanoma at earlier stages, and treatments are better. However, melanoma that goes undiagnosed and untreated can lead to death, so it is important to know what to look out for. So melanoma is widely considered to be the deadliest skin cancer. Here are some photographs of different cases of melanoma and how it can look on the skin. It can occur underneath the fingernails and anywhere on the skin. It typically is pigmented and dark in color. However, some melanoma skin cancers lose their pigment entirely and are pink, and those are the really scary ones. So what is melanoma? Melanoma is a malignant tumor that arises from melanocytes. Melanocytes are the pigment-producing cells within your skin. There has been a rising incidence rate of cutaneous melanoma observed over the past 4 decades in white populations. And again, it is a deadly type of skin cancer. We have a helpful mnemonic to help you know what to look out for in terms of these skin cancers. We call it the ABCDEs of melanoma. A is for asymmetry, B is for funny borders, C is for color variation. We don't like things that are jet black in color or a fusion of multiple colors. D is for diameter bigger than a pencil eraser. And E is the most important one. That's a spot that's evolving, changing in size, shape, or color over time, or a mole that's bleeding or painful. Now I'm going to switch gears and talk about the most common type of skin cancer, which is the basal cell carcinoma. And here are some pictures of basal cell carcinomas. They can look different on the skin. They tend to be pink in color. However, if you look at the photograph on the right, there is a pigmented version of basal cells which can be confused to the naked eye with a melanoma. Basal cells also occur on sun-damaged skin. They tend to grow slowly. They tend to be pink, pearly, with thin branching blood vessels over them, and they're locally destructive to the skin. Now I'm going to discuss some pre-skin cancers. These are called actinic keratoses, and they're precursors to squamous cell carcinoma. So on the photograph on the left, you can see these scaly patches on a gentleman's scalp, and then on the right you can see lips that are kind of white and with a mottled discoloration. So actinic keratoses tend to be rough, sun-damaged pieces of skin. On the lips, they can appear as chapped lips, peeling, or white patches, and they can be treated a variety of ways with liquid nitrogen cryotherapy, with topical chemotherapy creams, with a light treatment called photodynamic therapy, or with ED&C, which is a scrape and burn procedure. And if untreated, they can lead to squamous cell carcinoma. So squamous cell carcinoma can be an aggressive type of skin cancer, and it can appear differently on the skin as well. So this is just a series of photographs that show that some are distinct tumors, some are just little pink bumps, and on the right you can see a flaky patch. They occur on sun-damaged skin as well. They can occur on the lips of smokers, and they often grow quickly and are painful. Some people ask about a family history of skin cancer, and they want to know how this increases their risk of developing skin cancer. So basal cells and squamous cell carcinoma occur more frequently in patients with fair skin and light eyes who have had significant sun exposure. Genetics play just a small role in these more common skin cancers. In contrast, melanoma can occur spontaneously, or it can run in families. Disease genes have been identified that can increase the risk of this type of skin cancer. So if you have a first-degree relative who has been diagnosed with melanoma, then the American Academy of Dermatology recommends annual skin cancer screenings. I'm going to finish this talk with a mention of a benign skin growth called seborrheic keratoses. These are benign warty skin growths that are common in middle age. They can grow anywhere on the skin except for the palms and the soles, and they're often confused for moles, and they can violate some of the ABCDEs of melanoma. So we see these commonly in the office. We typically leave them alone unless they become irritated and they're rubbing against your clothing or something, and then at that point in time we can treat them. But we see these a lot, and we reassure people a lot that these are just harmless skin growths. The American Academy of Dermatology has a really nice website that has a lot of information for the public with regards to skin care and skin diseases, and that's the link. And I'm happy to take any questions.
You mentioned the thinning of the skin in older people.
Yes.
For your normal eruptions that occur, hydrocortisone, is that good for topical treatment?
When you're saying normal eruptions, are you talking about itchy patches or are you talking about bruising?
But maybe light scaly patches or whatever that don't look too bad and they go away.
Light skin, yeah. Yeah, make an appointment because, people can develop rashes that can be similar in appearance to pre-skin cancers. So red and scaly, it could be a few different things. So, yeah.
So those brown spots that we get as we age are really quite unsightly. And
Right.
people want to get rid of them.
Yeah.
Are there recommendations for anything, either over the counter or ways for people to be able to eliminate those brown spots?
Unfortunately, not yet. There is hope. There is a physician at Harvard. His name is Victor Neal. He has a cream in clinical trials right now that he's testing on his patients, not our patients, to get rid of these spots. In the office, what we have to offer for treatment for seborrheic keratoses is the liquid nitrogen cryotherapy. We can try to freeze them off the skin. We can numb them up and shave them off the skin, but these all lead to scarring, unfortunately. Yeah.
Looks like we all are.
Yeah.
In general, not like with people who have had any skin cancers or things, but like for young people, like, what age do you recommend they start having the total body skin check thing?
There's no age in particular, so we really do look at the family history as a good one. So a family history of melanoma, I would recommend annual skin checks, at 18. And then it does depend on their sun exposure and if they're having symptoms. So that's kind of a hard question to answer. I would say the average age for my skin cancer patients is somewhere around retirement age. So I have a lot of people coming in when they're 65 and they're like, I want a baseline, and I think that's completely appropriate. But some people do come in earlier and some people do develop skin cancers as early as the 30s. So.
Particularly if you're a redhead.
Exactly, yeah. So redheads have not very much protection in their skin against the sun. So it does depend on your skin type as well. So there's a scale called the Fitzpatrick scale. Most people in New Hampshire are 2 on this scale. Redheads are 1. I'm a 3. I have a Mediterranean background. And so the darker your skin tone, the less likely you are to develop skin cancers, though it can occur in any skin tone.
What are you seeing most often in your pediatric population?
We see eczema, we see acne, we see rough and bumpy skin we call keratosis pilaris. We see a variety of benign birthmarks.
Have you ever known of a birthmark going away? As someone ages. Now we're talking ages.
Mm-hmm.
When they're youth, but disappearing.
There are some hemangiomas that develop in babies. They're benign blood vessel growths that grow and then they involute. So that's possible. There are other skin birthmarks that go away. They're more rare though.
Because they say you should be watching your birthmark
Mm-hmm.
to see if it changes relative to skin cancer.
So congenital, so I think you might be discussing like a congenital mole. So there are different types of birthmarks. Some can be made of pigment producing cells. Those are like your moles or your nevi. And then some are made of different types of skin cells. You can have benign birthmarks made of smooth muscle, for example. And your birthmarks that are moles, that are have pigment in them, they have no more likely chance of developing into a skin cancer than the normal skin around it. And one thing that people are not so aware of, that I educate them every day, is that the moles that you're born with, they continue to grow, or most moles continue to grow throughout your life, so they can start as brown, flat spots, and as you age, those pigment cells multiply and they can become more elevated and dome-shaped, and then as you age even more, they can get wrinkly like raisins, and that's kind of a normal progression for a mole to go through.
Does that appointment to look for skin cancer, whole body appointment, does that have to be done by a dermatologist, or do you feel primary care are able to conduct that?
That's an excellent question. I think that primary care can probably recognize things that might be obviously bad, like bleeding spots maybe, but they might miss some subtle things. So if a primary care doctor isn't sure, it's best that they send to us.
So I have a question. My mom was just recently diagnosed with a squamous cell,
Mm-hmm.
and what they told her was the wart that they thought was a wart had actually been a slow-growing form for about 20 years.
Mm-hmm.
Can you talk a little bit about how things grow that slowly and why it didn't impact her until, recently?
Mm-hmm. So some squamous cell carcinomas can arise from warts. They can have a virus in them, the human papillomavirus, which typically the body recognizes and at some point eliminates. So she could have had a wart for many years, and she could have developed a mutation within that wart that transformed that wart into a skin cancer and told it to grow. So it probably wasn't a skin cancer the entire time. Yeah.
So that wart, that new papillomavirus, that's the same, we give a vaccine for that.
We do. So yeah, so we have a vaccine. It's the Gardasil vaccine. It is typically given to children around the age of 11 or junior high because it protects against strains of HPV that are prevalent in genital warts, anal cancer, throat cancer. So we try to give it to children before they're sexually active. Now there are dozens of strains of the human papillomavirus, some of which cause warts on the skin, like the hands and the fingers, or the rest of the body. And we have noticed that some patients who get the Gardasil vaccine, like if they have warts on their skin, their warts on their skin clear, even though it's for a different strain. Yeah, so there are certain sites where having a wart might predispose you to getting a skin cancer. Like if you have a wart that's next to a fingernail for a really long time, sometimes it transforms into a skin cancer. And at that point, I do recommend that they get the Gardasil vaccine, even if it's an adult who's 55 years old.
Well, that's what I was going to ask, because they only really do that vaccine for adolescents.
Right, right. I recommend it all the time, and I get it for my adult patients all the time.
For both sexes? For both males?
Yes, yes.
Huh.
Plus, didn't they move the age of the
So when the vaccine came out in 2006 or 2007, it had been tested on a population up to the age of 26. And then subsequently, they've been giving it to people who are older. Yeah, they originally it was against 6 strains, and now it's like 9 or 11 strains.
How do you convince a late teen, early 20-something, fair-skinned, redhead, blue eyes, that it's important to cover their skin?
Show them pictures of people who didn't cover their skin. There are actually apps that photo age you. So they're doing these studies where it's not in this field, it's in other fields, in academics, where they have someone take their photograph, put it in an app that ages them so that they develop empathy for their future selves. Right now they're studying it in like the context of saving money, because people don't want to save money for retirement. But I bet if you showed somebody what they might look like when they're older, they might be more prone to putting some sunscreen on.
Thank you.
Yep.
I guess kind of along those lines, is there a difference in terms of percentage of cancers rising from people who are of Scottish or Irish descent versus people who maybe aren't? Is there like a higher precedence?
So what they're detecting a higher incidence, but we don't know if that's because the rate is increasing or if we're just getting better at detecting. So no, they're not all caused by the sun. The sun can contribute to the development of basal, squamous cell, and melanoma skin cancers, but they can occur in non-sun exposed skin as well. So one example would be, somebody can have a genital wart that can transform into a squamous cell skin cancer, and I have removed those from people's genital regions. And then in terms of melanoma, melanoma arises from melanocytes, which are the pigment-producing cells. Those reside within your brain, within your spine, within your eye, and lining your intestines. So people can have melanoma that develops internally, and all cancers arise from mutations in the DNA, and you need the right combination of mutations to grow a cancer. One thing that people don't appreciate is every day you're making cancers, and every day your immune system is fighting them off. Any other questions?
As far as your melanoma, what is your first line as far as after you diagnose biopsy?
Yeah.
And then your treatment stages?
Yeah, so we look at the thickness of the melanoma to determine how we're going to treat it. So the goal for any suspicious pigmented lesion is to biopsy it, but to remove all visible pigment. And then depending on the depth, we do something called a wide local excision, where we take a margin of normal skin around it and make sure that there are no more skin cancer cells anywhere in that vicinity. And then if it's deep enough, we have to refer the patients to get sentinel lymph node biopsies. We do refer to our own plastic surgeons, and then if a sentinel lymph node is, for the sentinel lymph node biopsies, if it's positive, then patients become a candidate for immunotherapy, which they can get at either Dartmouth or Dana-Farber.
Basal cell is considered, relatively speaking, less aggressive.
Yes.
Because it spreads slowly and it doesn't metastasize. Could you comment on how many cases you see where it's invasive into other tissues and causes a problem that needs to be addressed?
I would say it doesn't commonly go much beyond the skin. On the ear, I've seen it go into the cartilage a lot. It's really common, especially the infiltrative variant of the cancer can get into the cartilage, and then people have missing cartilage. Yeah.
When you were talking, I believe, about removal of skin growth that could be potentially melanoma, and you were saying so after it comes back from pathology, yes, you have to remove it. Then you said you dig a little deeper to go around to the good tissue, and you stitch that up. Now, what follows that? Just checkup, or do you ever follow that with radiation or chemo? Which of the two?
No, so melanoma is not treated with chemotherapy, and we do not do radiation for melanomas either. So we do serial skin exams. So if someone's diagnosed with a melanoma, at least for the first year, they get skin checks every 3 months. Yeah, there's a chance of finding a second melanoma if you find a first melanoma within that period of time.
But in other parts of the body.
Right.
So melanoma in general cannot be treated through either radiation or chemo?
In general, we utilize immunotherapies that boost your own immune system. So melanoma is a really interesting cancer where back several decades ago, they found that people could have metastatic melanoma to their brain, and you would think that they're toast, but their body's immune system kicked in and cleared the melanoma completely from their body. And then in the early 2000s, they developed immunotherapies, checkpoint inhibitors, PD-1 inhibitors that boost the immune system. It's in a completely separate class of medications than chemotherapy, to utilize the body's own defenses to fight the cancer.
Did I hear you say you have to go to Boston for immunotherapy?
You could go to Dartmouth as well.
Just gonna, my name is Megan, I'm the dietitian in the Cancer Center here.
Okay.
Just a positive note on prevention that about 5 years ago we got a really generous grant from the Rotary Club of Concord to buy sunscreen dispensers. We just got another grant, so we're going to continue the project where we have free sunscreen dispensers at all of the Concord Parks and Rec pools.
That's wonderful.
Just for access for everyone, as well as umbrellas for all the lifeguards, education on skin cancer, melanoma.
I see a lot of patients who are lifeguards.
Yeah. So, in any event, just wanted to mention that.
Okay, thank you so much.
Well, I just want to say thank you so much, and thank you all for joining us today. I hope you learned something, especially as we head into the very warm weather. So we hope you'll join us next month, Friday, May 12th. It's with Dr. Rowe on radiation therapy. More details to come on that.
All right, thank you guys for coming.